Our next speaker, Hemi Tewarson, will discuss the COVID-19 response at the state level, including equitable vaccine distribution. Hemi is a visiting senior policy fellow at the Duke-Margolis Center for Health Policy. At the center, she is responsible for strengthening engagement and state-level COVID-19 response, including such areas as new models of care and effective strategies for testing and containment. She previously served as the director for the health division of the National Governors Association Center for Best Practices. Hemi?
Thank you so much, Catherine, and it's great to be with all of you today. So that was a really, I think, thoughtful and sobering perspective from Dr. Osterholm. But today I wanted to focus on his comments around vaccines, and that's really what I'm going to be talking about in terms of the state perspective and where we've been. And before I get into sort of all those details, I'll just make one comment about, state leadership on this. And they really had to lead because there wasn't a national plan. Governors were just propelled forward to having to deal with things like in the early days of shortages of PPE and shortages of, beds in the ICU, the ventilators, and identifying how to get their arms around testing when there wasn't enough supply. And there have been a lot of challenges. And to follow up on the point of fatigue, states have been on, and their public health leaders and all of the staff that work for them have been really under a lot of pressure. It's been, putting out fires since last March, and it's still that way. And so recognizing that this is sort of a marathon, not a sprint, is really, I think, part of what we are all trying to figure out how we can support states. At Duke-Margolis, I'm continuing my work of really engaging state leaders on different topics. Testing is one, but really today I'm going to talk about our work on vaccine access and distribution. And one of the things I wanted to talk about is how are states really getting ready for this? So as Dr. Osterholm mentioned, really great news with the Pfizer and Moderna effectiveness numbers, and I think we're all expecting a vaccine EUA to come in December. But when that authorization comes, the vaccines are expected to be distributed within 48 hours of that event. And, given the numbers that we're talking about, that is a massive undertaking, and states and localities and their partners at the, health system level and the community are doing their best to really get ready. But this is an unprecedented event. And it is not like just doing a flu campaign or vaccines like we've done in the past. This is a whole new way of thinking at a massive level. So I thought I might just start to talk a little bit about, who will get this vaccine and how do we need to think about that in terms of getting ready. So the National Academy of Medicine has recommended a phased approach. And, using that phased approach, phase 1A and phase 1B are really going to be, those high-risk healthcare providers, those that are on the, front lines really confronting, the most risk of transmission, and first responders. And phase 1B are people with high clinical risk and older adults in congregate settings because we've seen, such a high mortality rate among those populations. And then as you get to phase 2 and phase 3, which I'll talk about in a minute, you kind of broaden out the scope of, getting to teachers and childcare workers and other workers in critical societal industries and with exposure risk and people with moderate risk, et cetera. And then phase 3 is really where you get to the, healthier populations, the young adults and the children who haven't had quite the prevalence of the disease as it's, appeared in the older populations and people with comorbidities. And then you get to everybody else in phase 4. So if you look at this slide here, you'll see, there it is, how, there's going to be limited doses available in the beginning, and then there'll be more, and then we will continue on. And I think what we're focusing on right now with our work with state leaders is really that first piece. How do we really make sure, and help them get prepared for what is coming in this next really month before we see an authorization from the FDA. Go to the next slide here. So in terms of just the numbers, I thought it might be helpful just to briefly review. So when we talk about phase 1A, which is not just the National Academy of Medicine, but also CDC put out these estimates as well, they are looking at, just looking at healthcare personnel and first responders could be anywhere between 17 and 20 million of the population. And you see who's covered under that with people at risk. I think for the states, what they don't know yet is how many vaccines are going to come to their state. So, depending on how big their state is, how many of these different types of providers they have, states are having to think about subcategories within the big category. And I'll talk a little bit about that in a few minutes about, the challenges of making sure that you're ready, but you don't know exactly how many you're going to get, which is, a little bit of a chicken and egg, determining how to prepare. If you look at phase 1B, which is, still the first phase, but the second tier, it's, that could be more than 100 million people, with people at high clinical risk and older adults. And 19 to 20 million of those folks may be at the highest risk because they have multiple comorbidities, and then you have another group that's qualifying older adults at over 17 million, but it could go up to 53 million if you include all of above 65 years of age. Okay. When you get to phase 2, you can see, you get to the teachers and the essential workers, the moderate clinical risk, homeless folks, people in prisons, and all other older adults. The estimated population, is greater than 38 million, but could be more likely to be 100 million. So I just share these numbers because I think it illustrates the challenge we have in front of us as a country of, getting people vaccinated at the numbers that we're really thinking about. And I think it is part of the critical solution to really ending the pandemic, but this is going to be over sort of a long period of time, not in the next month, not in the next 2 months, but really over the next year, really being able to get to everybody. And you can see here, phase 3, when you get to the young adults, children, essential workers with moderate risk, you're at 152 million. So just to get to the part about states, so, states were required to submit their plans for vaccine distribution and access to the CDC back in October. And one of the things that we are doing here at Duke-Margolis is we're partnering with the National Governors Association to review all of the plans and really identify kind of what are the key themes, where are states starting to strategize around these different challenges, and how can we, make this sort of a useful resource for when states continue to refine the plans, which they are all doing. Those were just interim planning documents. They had a month to do them with not complete information, and now, they're continuing to refine them as they get more information and more understanding about what's to come. So if you're interested in that, in this topic, we will have a paper coming out in December, and happy to coordinate through NIHCM to make sure that, people can get access to the paper. It will be publicly available. But anyway, back to this, in terms of what states are doing to actually plan, in the plans, there were different categories that they have to address, which the CDC required them to do. And one was like, how do you identify and allocate vaccines to critical populations? And you just saw with my previous slides, really even just focusing on the phase 1A, there could be potentially a lot of people in that phase, and understanding who they are and how you're going to get the vaccine into their arm. The last mile, which is the states and localities are going to be responsible for, is going to be the challenge they're going to face when the vaccine is authorized in December. Along with that is, how are they going to do some logistical planning to meet vaccine storage and handling and administration requirements? How are they going to support vaccine provider enrollment, making sure you have, enough people enrolled who can administer the vaccine, vaccine ordering and distribution and storage, which I'll talk a little bit about in a few minutes. The Pfizer vaccine, for example, requires pretty significant cold storage. And so not every facility is going to have that capacity. And so figuring that out ahead of time when you perhaps don't know the exact number of vaccines that you're going to get, and when you're thinking about places like rural populations and providers who may not have that capacity, how do you handle that? And then engaging providers, partners, and communities and communication. So this piece I'm going to spend a little bit of time on as well. I mean, really, we have seen a lot of concern around, the vaccine and whether it's going to be safe to get the vaccine, and people, who perhaps were not vaccine hesitant really coming forward as vaccine hesitant. And so there has to be a lot of work done on really being able to effectively communicate about, here is why it's important to get this vaccine. Here is the science that we know that supports its safety and efficacy, and here's how you're going to be able to get it over time. I mean, I think the other part of the messaging that we're really going to have to focus on is not everybody is going to be able to get it in that first month, even within, those groups that I showed you earlier. And so making sure it's clear to the public how this is all going to work is going to be critical, and it will be critical for us to get it right in the first instance as opposed to, you know, not getting messaging out until later, and, you know, things happen and things won't go perfectly. They never go perfectly, no matter how hard, you know, there is an effort to plan for them. But, you know, being able to make sure that there's an understanding of how this is all going to work is going to be critically important. Okay, I'm just waiting for the slide. Okay, so I just wanted to focus a little bit on some key challenges. So before I get to this identifying and allocating to the critical populations, I wanted to talk big picture about a few things that states have raised. So, you know, given the sort of the massive nature of this vaccine effort, which you saw with the earlier numbers, funding. Funding is going to be a huge issue for states. Dr. Redfield himself has estimated that we need $5.5 to $6 billion to help fund this effort for states and localities across the country. And they're going to need funding for things like, you know, making sure they have enough personnel to administer the vaccine and educate folks, to make sure their data systems are going to work, and to really engage in a communications campaign that's of critical importance. I think the other challenging piece is there's really need for additional guidance for states. So, you know, we're all waiting on complete information about the vaccines, and on the safety side, really understanding it's going to be safe for which populations. And so that's going to be, I think, really important for getting the public trust of, you know, who should get the vaccine first, and, you know, should I be signing up and be talking to my neighbors about, you know, why it is a really good thing to get this vaccine. The American Committee on Immunization Practices, or otherwise known as ACIP, is going to be, I think, a key element of this, of really looking at the EUA that FDA issues, emergency use authorization for the vaccine, and being able to provide guidance as to here's our recommendations on who should actually get this. A number of states are waiting for this. They really would like to see the ACIP recommendations before they launch in their states. And so I think the hope is ACIP will act very quickly after we see an EUA to make sure that there's that piece of evidence that states can rely on. I think states also are really hoping for very quickly to understand the criteria for the initial allocation. So, you know, what are the factors we're going to look at? Is it going to be, you know, total population, number of healthcare workers, number of people in nursing homes? Is there going to be any element of, you know, disease transmission or prevalence? How does that all going to fit together so they can have a sense or a guess of how many vaccines they may actually get, which can help them then plan in terms of, you know, we're partnering with different health systems here, and here's what we think we can get, and here's like the percent of the population we're going to be able to reach in this first push, especially, as I said, you know, an expectation of quick movement after that EUA is initially issued. Data requirements. I think there's a lot of questions around how do we understand more of the data requirements so we can make sure that our systems work as they should, and that we can share data with the federal government as well as share across states. So I'll talk a little bit about that too. And then, of course, they want more information on communication resources and provider training. One thing, you know, with different types of vaccines, I think it's going to be fantastic because there'll be more vaccines for more people, but they have different requirements. So how do we train those individuals so they understand the different requirements of, like, you know, a cold storage versus a vaccine that doesn't need that type of cold storage, 2 doses for a vaccine that doesn't need 2 doses, et cetera. And I really should probably keep moving on because I'm going to run short on time, but there's also a couple of state-specific factors I wanted to just highlight. You know, there's some states that have a lot of rural areas, for example. So workforce capacity and, you know, rural locations have cold storage, and how do we reach populations is going to be, you know, particularly challenging for them. There's also sort of weather factors of how do you think about, you know, mass distribution sites. If you have a state that's very, you know, has pretty severe weather, okay, maybe that's not a reasonable way to think about it. And then there's also public health governance, which is, you know, whether it's centralized or decentralized, and how that can impact the work that states have to do to actually get the vaccine into the arms of people. Okay, so just briefly on the identifying and allocating early vaccines to critical populations. So we know the initial supply is going to be limited. The framework I showed you earlier will have to be adapted to state conditions, population, and infrastructure. And states are going to have to develop a clear, transparent process for allocation, getting input from, you know, both the federal government and the community, and really using equity at the forefront. So I think there's going to be a lot of hard decisions depending on how many vaccines a particular state gets and how large they are and how much of the population they're going to want to serve. A couple of examples of just in terms of how states are trying to get their arms around this is some of them have established advisory committees to try to help make sure that they're going to be able to make the right decisions very quickly. Some have already decided, look, we know we're not going to have enough for every, healthcare worker at risk, so we're going to, prioritize people who have 2 or more comorbidities. Some have decided, there's counties that really have just elevated disease transmission. We're going to, try to start there first. And other states are doing surveys of providers and provider organizations and working with our hospital associations to say, hey, can you tell us who you think are going to be the people that you or think are going to be most critical to actually get the vaccine? So, there's different, I think, strategies across the spectrum, but there is going to be a real need to make sure the right population is identified quickly. I want to just spend a minute on talking about operational planning. I talked a little bit already about the cold chain storage challenges and how, some of the Pfizer vaccine is going to require a second dose. So you're going to have to make sure that people are following up and get that second dose. A couple of things I also wanted to mention here is recruiting and enrolling providers. So this is going to be key, and states are of course going to leverage the providers that are enrolled in their Vaccines for Children program and their existing state immunization information systems, otherwise known as IIS. But really, in some states, they had to think about, okay, who is going to have that cold storage capacity? So is it going to just be the larger health systems and pharmacy chains, for example, initially? As we think about, sort of down the chain of when more and more people have availability for the vaccine, there's more vaccines available, the states are also going to think about non-traditional providers. And some states have already said, we're going to expand our scope of practice for professionals so we can make sure that EMTs and paramedics can administer vaccines. We're going to look at other types of providers who can administer these vaccines, and thinking about even down the road, when we really have to get the public trust for really being willing to get the vaccine, and also access, right? Making sure access is available for all the different populations, including, communities at risk where there is, Black Americans and Latinx populations where there is right now a fair amount of distrust of the vaccine. How do we get it to those folks? And there are different considerations. Some states are going to, of course, rely on mass vaccination clinics and primary care providers and pharmacies and local health departments. But they're also thinking about, maybe somewhat non-traditional providers like mobile units, harm reduction sites, churches, places in the community where people feel like they can go. The other thing I did want to note too is, all of this distribution sites initially will be closed point of distribution. So they are not going to be open to the public. They're really going to have to be limited to getting it to who is actually going to fit the criteria. Okay. In terms of data systems, I just want to spend a minute on this because this is going to be, states are working on this and will continue to be working on this with the federal government. So, states all have immunization information systems. The challenge is, given the sort of massive amount of vaccinations that are going to have to be given to folks, some of the current systems at states are not, they're not going to be able to handle the volume. And all the capability that's going to be needed for this vaccine. So some are, thinking about, okay, we can use our current systems and add some additional, complementary functionality. Others are saying, okay, we're going to have to integrate it with third-party tools. And then there's another group of states that are saying, well, we're really going to have to supplement it with the federal technology, such as like the CDC Vaccination Administration Management System, otherwise known as VAMS. So there's definitely variability in terms of how they're going to be able to effectively track the vaccine. And this is really important, being able to track the vaccine, making sure people get second doses, and then also identifying where there's any adverse events, because that's going to be a really important information chain to establish to inform sort of the next phase of distribution, making sure we understand who gets it and what happened to them. One challenge I just did want to highlight for this group. So there is a system called IZ Gateway that was established years ago at the federal level, and it supports data exchange amongst immunization information systems. And so, in a perfect world, as it was visualized, you would be able to put information into the system, and then, there could be a lot of sharing at the federal level across states of, who's getting the vaccine and how are things getting impacted. I think the challenge with this is it was established a couple of years ago, but only 2 states currently live on it. It just hasn't kind of been implemented in a way that other states have been able to really participate. So although a number of states, and most states frankly, say they're planning on using IZ Gateway, there's going to be some work in order to make that a reality. One of the pieces also is States have to sign data use agreements to allow the sharing of information with the federal government and others. And there has been some legal issues around whether their state's laws prohibit the sharing of identifiable data. So I think there's more clarity that's needed around exactly how will the data be stored and shared, and how does that comport with what may be prohibited at the state level. The last thing I want to mention, which isn't on this slide, but I want to be sure to highlight for you, is a couple of states also in their state vaccination plans identified data dashboards for public reporting. I think this is really important, given the concerns around getting vaccines and the need to really build public trust. Having an outward dashboard that shows, here's who's getting vaccinated, here's how, here's the information of where you can get vaccinated, et cetera, is going to be really important. And so some states have flu dashboards, and they're thinking about how to build the COVID-19 vaccinations into those dashboards. Other states are thinking about different technology on a public website, et cetera. So I think it will be interesting to see how that all plays out, but I do think there's an interest in really making sure there's transparency for the public. Okay, and then, there we go. And then really, this is the last slide, and I'm going to turn it over to my colleagues. I want to just talk a minute about vaccine communications. So I talked a little bit already about how there's been kind of diminished public confidence in the integrity of the FDA approval process. I had an old headline here because I just wanted to remind everybody of kind of where we were before election. A lot's happened since then, but where we were before election of, people really worried about getting a fast approval. I think the work done by the manufacturers and, some of the good news that, Dr. Osterholm shared at the top of the call about the effectiveness of the vaccine, hopefully is going to go a long way in making people feel like it's safe. I also think once we see the actual safety data as part of the approval or authorization by the FDA, and then the ACIP recommendations that follow it, hopefully will provide a really good basis to say, this is a safe and effective vaccine for these populations, and this is why it's going to be important to make sure people are vaccinated. I think a piece of that is really making sure that the public understands, and not just from, governors or mayors, but from other folks, the people they trust, their doctor, their nurse, their neighbor, where there's a conversation across the country at different levels of, what is this vaccine and who should get it and why, and how this is going to be a critical piece to sort of solving the pandemic that we find ourselves in that is unprecedented. I wanted to talk just a minute about the disparities, and really, we all know that healthcare disparities exist and have existed for a long time. COVID-19 just shown a spotlight on it, frankly, for Black Americans, who in some states had mortality rates and case rates that were like 5 to 1 initially in states like Michigan. So, it's really been sort of stark comparison to see that, and also with Native Americans and Latinx communities. And so, getting to those populations and making them feel like they can trust the vaccine and giving them access to it in a way that works, I think is going to be a critical part of us reaching those populations and really trying to address the disparities that we know exist. So with that, I know I should turn it over back to Catherine, and happy to take any questions in the discussion.
Thank you so much for sharing all this important work happening in the states and what still needs to happen to promote widespread access and acceptance. And we look forward to staying in touch on your continued work.